Challenges in health technology assessments of genetic tests. This presentation is based on our publication in the Journal of Hospital Management and Health Policy. I thank my co-authors. The outline of the challenges discussed. Genetic tests detect changes in chromosomes, genes, or proteins. In recent years, the use of genetic tests has grown rapidly worldwide. Compared with traditional diagnostic tests, genetic tests have new features that bring additional challenges to health technology assessments, also known as HTAs. Consequently, standard methods for meta-analysis and economic evaluations may need adaptation. We reviewed 3 HTAs for genetic tests and provided specific considerations relevant to the evaluation of genetic tests. While these issues are especially relevant to HTAs of genetic tests, they may also apply to non-genetic health technologies. First, Bayesian meta-analysis for a rare genetic condition. In our non-invasive prenatal testing HTA, we identified 7 studies reporting the sensitivity and specificity of trisomy 13. 6 of the 7 included studies had at least one 0 cell in its 2x2 table, and 3 studies had 2 0 cells. We were unable to obtain summary estimates of the pooled sensitivity and specificity using a frequentist method because the models did not converge. We instead applied a Bayesian bivariate meta-analysis model for diagnostic test accuracy that uses a beta distribution for the prior probability distribution of disease prevalence, which is appropriate for cases of low disease prevalence. The Bayesian model was computed using Win bugs to avoid issues of non-convergence. Genetic diagnostic tests commonly lack a perfect standard, the inability to definitively determine disease status, for example when the comparator quantifies a biomarker such as enzyme activity where the cut point varies, or if the comparator is a genetic test that includes different variants. The classical meta-analysis models assume that the reference test is perfect. If the test being evaluated has higher sensitivity and specificity than the reference standard, and the reference standard is assumed to be perfect, then the additional patients correctly classified by the new test would be erroneously treated as false positives or false negatives. Dendekuri and colleagues extended the HSROC model and developed a Bayesian latent class meta-analysis model in the absence of a perfect reference test. This model can adjust the imperfect reference tests and the conditional dependence between tests. In addition to estimating the sensitivity and specificity of the test under evaluation, these models can also be used to obtain estimates of the sensitivity and specificity of the reference tests, the magnitude of conditional dependence, and the true disease prevalence. Previously, researchers used Win bugs and Open bugs software for the latent class meta-analyses model. More recently, Dendekuri and her team developed an Shiny app for several meta-analysis models. This app is user-friendly, and users can run various analyses online. Economic models have been developed to account for conditional dependence between tests in the absence of a perfect reference standard. You can read the article titled Developing Economic Models for Assessing the Cost-Effectiveness of Multiple Diagnostic Tests, Methods and Applications for the guidance of applying this method. Defining the true disease prevalence. Disease prevalence is often one of the key parameters in determining cost-effectiveness results. However, in many cases the true prevalence of a genetic condition is unknown. For example, patients with negative screening test results, including false negatives, are often not investigated further. The observed prevalence may not reflect the true prevalence for various reasons. When the observed prevalence may not reflect the true prevalence, researchers should estimate the expected true prevalence under some assumptions. Based on the observed live birth prevalence and the spontaneous pregnancy loss rate, we provided an example of estimating the true prevalence of trisomy 21 among fetuses at 12 weeks of pregnancy, the typical time that prenatal screening for trisomy 21 occurs in Canada. In this example, the prevalence of trisomy 21 at 12 weeks of pregnancy was much higher than the live birth prevalence of trisomy 21 in the absence of prenatal screening and voluntary termination of pregnancy. Health outcomes and time horizons used in economic modeling. Economic evaluation guidelines often recommend using quality-adjusted life years, also known as QALY, as the primary measure of effectiveness along with long-term time horizons. But there is often no source of health utilities that fully matches the target population. Also, evidence on the long-term effectiveness of a health technology may be scarce. Thus, short-term economic modeling of clinical outcomes may be of value to inform decision-makers. Lastly, costing of genetic tests and the analytic perspective. In addition to the cost of the genetic test itself, there are often other associated cost components, such as sampling, laboratory preparation, bioinformatic analysis, data management and storage, and interpretation and reporting of genetic test results. Compared with other types of tests, clinical interpretation of genetic results can be much longer and more costly. For example, in addition to regular physician visits for testing, some genetic tests may also require pre-test and/or post-test genetic counseling to discuss the detectable genetic conditions of interest. The test's detection limitations and its role in detecting other conditions, family or personal history of the conditions tested, or appropriate further testing options. Genetic counseling also incorporates ethical and legal components. In summary, the full cost associated with genetic tests are generally greater than the cost of the test alone. Genetic tests may be performed in commercial, hospital, or community laboratories. For commercial tests, industry often sets a list price. For hospital-based tests, we need to consider whether the infrastructure, equipment, and setup costs should be incorporated. The societal perspective is particularly relevant for genetic tests since caregiver and familial spillover effects may often occur. In conclusion, standard literature review and economic analysis methods may require adaptation for HTAs of genetic tests. Now, I summarize the key messages. Bayesian meta-analysis of diagnostic test accuracy is particularly useful for rare genetic conditions and in the absence of a perfect reference standard. When developing economic models of combined tests, researchers need to consider adjusting for conditional dependence between tests. When evaluating the cost-effectiveness of genetic tests, researchers should pursue the unobserved true prevalence of the genetic condition of interest. Long-term time horizons and QALY may not always be suitable in cost-effectiveness analyses of genetic tests. In addition to the cost of the genetic test itself, there are often other cost components associated with testing that should be explored, including spillover effects. Here is the timeline of this article. Thank you.